just running a little bit late. Well, I have no apologies because we've just had our patient story. No, sorry, I have no apologies for the patient story. Sorry, that took just a little bit of time, but it's necessary for us to hear that. So just in case you were wondering why we are half an hour late, but we are starting. So welcome everyone. There's a few people in the room with us today, more than we usually have, so it's good to see you all. It might be worthwhile if you would like us to introduce ourselves so that you know who's around the table. Would that be helpful for you? So I'm going to start with BD.
Welcome, I'm Jenita Arya. I'm Consultant and Executive Director.
Welcome, my name is David Tito. I'm the Associate Director of Corporate Governance.
Morning, I'm on the
Morning, I'm Patrick. I'm Deputy Chief Executive and Executive Director of Strategy People Partnerships.
I'm Sue Bedford, Non-Executive Director.
Morning, all. I'm Vanessa Devlin, Executive Director of Operations. Morning, everyone. I'm Rob Bean, I'm the Chief Executive.
And good morning everyone, I'm Phil Gale and I'm the Trust Chair. Hi, I'm David Tomlinson, Director.
Morning, Val Clare, Non-Executive Director and Deputy Chair.
Good morning, I'm Lisa and I'm the Deputy Director of Infection Control, Patient Safety and Policy and Finance.
Morning, I'm Linda Cullen. I'm Non-Executive Director and Chair of the Quality and Safety Committee.
I'm Hannah Sullivan, I'm Corporate Governance and Management Manager.
Morning, I'm Leona, I'm one of the governors.
I am Tom, Associate Director of Communications.
I'm the Deputy Office of my name is Chandra. I'm one of the program management from Monsanto Research.
I'm Sadie Marcelo, Chief Psychological Professionals Officer for Trust. This is my team.
Yes.
Good morning, I'm Christiana Akinfolari. I'm Practice Business Manager with the Corporate Psychology team.
Morning everybody, I'm Jacob Rogers, also Practice Placement Manager for the Corporate Psychology team.
Morning everyone, and my name is Nicola Glover and I'm one of the project support officers.
Brilliant. Well, welcome everybody. It's good to have you in attendance with us today at our board and public meeting. We're going to start the agenda and just ask if there are any apologies for absence.
Thomas Keating and Sarah Bloomfield, but Lisa Pimmins here to represent the staff.
Brilliant. Are there any declarations of interest in relation to the matters on the agenda people would like to note? No? Okay. So moving on to the minutes of the meeting held on the 7th of February, I'll just ask, just to save time, are there any matters of accuracy or anomalies? In relation to the minutes. Oh, we also needed to mention count as absent.
Yes.
Okay. So moving on then, matters arising from the meeting held on the 7th of February.
It's complete, so.
Is it complete?
It is.
Just getting the papers on that. Okay. Okay, so we shut our computers down. We have the page installed. So mine is very slow. Computing. So just moving on to my report, just to save time. The report is there, and I'll just try and just draw out some kind of highlights for you. just wanted to mention that in relation to the service visits. So I visit the trust services every week. I try and ensure that I'm at one of our sites across Birmingham or Solihull every single week. Hannah's been absolutely great in booking me into the different services, and I've thoroughly enjoyed them. I have been and visited since the last board meeting. Our Health Exchange colleagues was honoured to meet the staff there, and they provide complex services, which includes homelessness provisions. And they actually work in quite a challenged environment, and that's all of the staff. And I was so impressed in my visit there, even with the receptionist who gets a barrage of abuse and manage it really well. We have quite a high turnover of receptionists at Health Exchange, but it was really glad to visit there. Also, I visited Ardently and met with the teams across the wards there, and it was actually great to see the staff again working together to deliver the best services in often a very, very challenged environment. Also visited the Oliesta, and was pleased to be able to meet with staff from a range of services. What's great for me to do is also to visit services in the Solihull area, so I had an opportunity to visit Dalmuni and Don Bromley services. Again, it wasn't too long ago that I visited their service, but it's great to see progress. Can't wait to see the redesign of the garden as well as it's currently underway, and also had the opportunity to visit the Barbary Centre as well, and meet with the teams across the wards there. Obviously, in relation to partner system development and stakeholders, I attend the NHS ICB Trust and Trust Chairs event in London, and it was hosted by Amanda Pritchard. That was quite an interesting meeting. It was all around the finances, but it also gave me an opportunity to network with other chairs across the country and hear about some of the good practice that they're doing in their services as well, which was really good for me to hear. And actually, there isn't anything else in my report that I want to specifically pick out because I'm trying to save time, so happy to receive any questions if there are any. Okay. Well, we'll move on and go to the Chief Executive Operations.
First, and then we can ask for permission, if that's okay. So just a few things that I wanted to highlight over and above the fact that I'll take the report as read. From a quality point of view, just wanted to acknowledge that since writing the report, we've had both the independent review into the incidents in Greater Manchester and the rapid review undertaken by the CQC at Nottingham have been published. And so just to give some assurance to the board that we've received those, and we will be taking those through our normal governance to determine what actions and learning there is from those for us as a similar organisation. I just wanted to also say from a sustainability point of view that the planning guidance hadn't been received at the time of writing the report, but was indeed received last week. It has detailed for us much of what we already knew and were planning against, but of course we are looking at it in more detail now just to make sure that that is exactly the case. You'll be appreciative from reading the Health and Care Press and from Phil's report too, and some of the other reports in our board pack, that actually the financial situation is predominantly becoming more and more significant for us. You will know that there's been a report about the inflationary levels being fairly low, so that in itself means that we're going to have to go faster to stand still, and that in fact we've got much more significant requirements around finding efficiencies. We've had some discussions already, a number of discussions in the organisation. We've particularly spoken with our senior leaders in the organisation on 2 occasions now and we're firming up some areas for us to be focused on based on those discussions that we've had through. I wanted to point out a couple of the reports that I've included for reference, one being the King's Fund report around vacancy rates in the NHS and social care. This is helpful to us, I think, in the it's not joyous reading, but it's helpful to us in reminding us about the context in which we're working, where NHS vacancy rates are about 8.4%, which is 5% above what the UK general vacancy rates are. Really pleased to say that the Department of Health finally agreed a definition of parity of esteem. We've been talking about parity of esteem for mental health services for some time now, and really important milestone, I think, in terms of that definition. They've also, as you will see, set out some building blocks that they see being needed to help us to get there. I think there's also something clear about how we use this in the coming years, particularly in the next 2 years, around thinking with external organisations and others around what does this mean for the kind of services we need on the ground, and the kind of funding that we might need to go alongside those. So the original 5-year plan was developed to support beginning to provide parity of esteem, and we know it's still a long way off from that. This second benchmarking report, the benchmarking report is the second report that I'd like to point out, and I think this really talks to a number of things that are going on in the organisation, and I think actually also links to those of us that were here from the patient story earlier, where it really makes clear about the level of demand that's been increasing whilst we continue to try and provide transformation. And I think there is something here around what does that mean for the kind of services that we continue to provide in a very specialist way, which I know is the point that Linda was making during the patient story. And secondly, how do we reset expectations of mental health services? Because what we're really clear about is that people talk about community mental health services, and I think people mostly talk about them in that traditional way of CMHTs. We have a range of other services now. 24,000 people in the last year have benefited from us having new ranges of community services in place. But I'm not convinced that expectations of what services are available and what therefore what should be required when people enter services is aligned. So I think there's quite a lot of work that we need to do. I'm really pleased to announce, I know the board members are already aware of this, but this is the first opportunity to say this in public, that our new executive director of quality and safety, who will also be our chief nurse, has been appointed and will join us in May. We look forward to welcoming Lisa at that point. And then finally, just a couple of things on the people side. I wanted to thank everybody who engaged really positively in our celebrating the History Month, both for women and for LGBTQ plus communities. Really good engagement in the organisation and recognising a number of our colleagues around that. And I also commend those that are involved, in particular Imran, our Deputy Medical Director, for the work that's going on around reducing our reliance on agency from a doctor's point of view. And finally, I know many of us have been involved in the awards judging. Thank you to everybody who made nominations. We had many more nominations this year than we had last year, over 300. So that made it really difficult for us, and we look forward in June to be able to announce the decisions that the judges have come to around who's going to receive those awards.
Thank you.
My glasses on. So we've quite a long report this month. Thanks to Kumar for topping and tailing it for me while I was on leave. So thanks to you, Kumar, as my deputy. I'll pick out some salient points and then just go through the reports, just because I know where everybody is, I should have had an opportunity to read it. So if I start with our Integrated Community Care and Recovery Services, or ICCR, as we like to call them, just to say we've got some changes in the leadership there. So a very, very strong leadership team. Elaine Marie is retiring after 30 plus years of working in our organisation. We've got a good set send off for her here in May to celebrate that. And Renu Padia is going to be the new director, associate director. She'll be taking up that role in May. She's currently the community, the lead for the community transformation at this moment in time in ICCR. Both of the clinical directors as well have had promotions, which is really good, working more closely with Abida. And they're taking up their new roles in the forthcoming months. So we're recruiting two new clinical directors there. So our thanks both to Sudhira and to Saraj for their work that they've been doing in ICCR. Just wanted to note again around the framework, the new neighbourhood pathway as part of the community mental health teams. Again, we've been counting how many contacts we're having and the outcomes. So we've seen 24,000 people within the year, which is, exceeded our expectations of contacts and people we're going to be seeing. Put some sort of really nice comments in there. So what the divisions are trying to do is bring the service users sort of voice and comments into their pieces. So there's some really nice, good sort of positive feedback there from some of our service users who've accessed the service. Really pleased that the community matrons have taken up post. They'll be specifically focusing on the adult community mental health teams, specifically looking at areas that we picked, which were highlighted as part of the CQC inspection. So there's focus there around compliance with risk assessments, medicines management and care planning. So that's really, really good news there. If I move on to secure and offender health, again, always note there, our challenge around RMNs across the division. But again, how everybody is helping and supporting, bringing in bank staff, and occasionally the matrons and managers are in the numbers on the board, supporting to enable the supporting of the activity. Continuous recruitment is taking place, which is part of the plans. Got new students and more internationally educated nurses starting in the division, which is really great news as well. So really, really proud of that. Moving on to Tamarind, one of our other units in the east of the city. I'm really pleased that they won the Team of the Month. So we've put that in the report to celebrate that, which is really great news to have that award. The team are very, very proud. And another change in management is around Emma Watts, who's been appointed and promoted as our head of quality in the provider collaborative, and Sam Bailey's taken up that role. Is taking up that role quite soon, so there's really, really good news there. I think just finally, just to note in secure and offender health is the results from the staff survey. All the divisions now are looking at and working on the results from the staff survey. So really, really positive developments with 45 out of 96 indicators made improvements. So well done to the team in that division. If I move swiftly on to acute and urgent care, again, very, very, very busy division. Lots of focus as ever around our out of areas, looking at our productivity plan, and the steering group continues to meet on a regular weekly basis. We're putting some more focus, particularly now around our detox. There's a change in classification of the terminology will clinically ready for discharge, and that's kicked in from the 1st of April. Looking at how we can reduce our clinically ready for discharge service use on wards who are due to move on to other establishments mainly. I'm working with our local authority colleagues in both Solihull and in Birmingham, and with our voluntary sector to really help us with that refocused piece of work. If we move on to there's notice about the seclusion room in Caffra. There's been an upgrade there, so having to plan around the not being able to use that seclusion room. So looking at how we can sort of mitigate against those potential risks. And also wanted to note here around the work that the division is doing around the extension of the professional nurse advocate role. I had a really good conversation with the head of nursing and AHP yesterday with Sophia around what those roles are doing and their undertaking. So she's looking at the roles, increasing their training and looking at how they can help and support with clinical supervision across the division. So she's really, really proud of sort of recruiting there and sort of testing it out in that division to roll out more across the organisation. So that's a really good role that they're implementing. And finally, on to specialities. Again, lots of work doing the older adult wards and the recruitment of internationally educated nurses. So they are, again, really, really well welcomed in the division. Community mental health teams are expanding their successful Silver Sunday, which are roadshows that they're putting on, and again working with Birmingham community and the our healthcare around a wide physical offer as part of those roadshows. Just wanted to note the Veterans Service also, they're having a Midlands Away Day, and looking at sort of the underspend that they've had as part of the service around additional help support and investing in the voluntary sector to do that. And then probably just finally the Barbary services, as all services are looking at discharging, making sure that people are getting to the right place after spelling our acute units. Discharge management is working really well across the division there, looking at the medically fit for discharge. And there's been improvements with the waiting list in both neurology and in eating disorders, which we've had a bit of a hotspot piece of work looking at that. So that's been improving over the past months. I'll leave it there if that's okay.
That's fine. Thank you. Thank you, Rashid and Vanessa. I'll open it up for questions. I'll open it up to the board first.
Thanks, Bill. Just a quick question on Rashid, in your report about mental health services in the UK and the benchmarking data. It'd be good to see more about that data, and apologies if it has been circulated across the trust, but it'd be good to see that in the context of performance and finance, just to see how, because there's some interesting trends there. 11% increase in referrals, that's a huge amount. It'd be good to sort of track that, emerging trends across our journey, and in terms of what we're commissioning, what's our cost base is, etc., so that we can actually then be quite robust in terms of how we tell our story against that. I think it'd be good to see a little bit more of that.
We currently, when we receive benchmarking reports, we do take them through the performance delivery group, and we ask divisions for whom they are relevant to do the so what pieces of work. We've also more recently done a piece with the CQC where we shared the latest benchmark work that we have done. So yes, absolutely.
That'd be great, particularly the way sort of Julie Kelly is challenging, the NHS in general. In terms of this is how much money we've pumped in, and we've not seen the return in terms of efficiency.
I think it's really apparent in the investment in mental health has, I don't think we can demonstrate it in terms of outcomes at the moment and what those have been, but we can absolutely demonstrate that the level of investment has produced enabled us to meet much greater demand.
Sure.
So I think those figures, so the 24,000 is based around investment that needed new staffing, and that's 24,000 people in 1 year, and our trajectory was nowhere near. But that's new demand that had you not been doing that, would have had to have landed somewhere else.
Indeed. It's just good to have it from, not only from an assurance perspective, but also from a robustness from a trust perspective.
Yeah, I was just respond to that. I was thinking of if we can pull the report through the performance delivery PPP committee, so we can share some of the results there. That would be helpful.
Great.
Yeah, thanks. So just in relation to Catholic PQ and the seclusion, I'm just thinking about the work that we do with the West Midlands Collaborative around how we can work together around PQs, whether that probably be an opportunity to test out within that collaborative space. Just in terms of the options appraisal, we can test that out, and I know we have our session on Monday, and that might be a good space.
Yeah, thanks Patrick, so that's definitely a good idea, we'll do that.
Can I just a couple of questions? So, firstly, on the Doctors' Industrial Action, again, we have that took place on 24th and 28th. 42% of junior doctors took part in the strike. And I guess my question is, I mean, it's the third. It might be the fifth. What impact? Because it doesn't state it in here, but what impact is this actually having on our services?
So hundreds of appointments have to be rescheduled. And we keep track on that, so we keep track of how many each time, how many appointments have been cancelled, and when they're cancelled, they're rescheduled, and how soon they're rescheduled. I mean, we've talked before, I think, and here at P2 about our sense is that the impact may be longer term rather than the immediacy. So what is the impact of not having had that appointment, or having had it delayed, or having had it been provided by someone else, someone that you wouldn't ordinarily have seen. So I think it'll take us time to work out what the actual impact from individual service users has been. But what we're able to track at the moment is the hundreds of appointments that need to be rescheduled and how they're rescheduled.
And my concern around that is that there are potential further industrial actions to take place. So the magnitude of the impact could be huge, and I think it's just worth noting that at our board meeting that it's not they're not going to change that per se, but it's just recognising that the continuation of the industrial action with the junior doctors. I think it's just the junior doctors at the moment. It's not the consultants. Will have, as you said, will have a lasting impact. At least it's the magnitude of that as these continue.
And what we are seeing, as the report suggests, is that we're seeing, as time goes on, less engagement, but actually we're also seeing less engagement in terms of us providing cover. So, people worked really hard last time round, much harder than they've had to do in the previous rounds, because people, getting people to come forward again to provide the cover was really difficult.
Just to add, we are also discussing it in the system with the other medical directors, because even our patients have appointments for physical health, so that's also concerned because they have cancellations. Make sure, and when we look at our serious incidents, we are looking at the timeline and if there's any correlation of any sort, so we can pick up anything this way. So there's a lot of work going on trying to catch anything that's happened during the strike period, but there's a lot of effort going on to make sure that we give safe services throughout the industry action.
Thank you.
I think that's what I was going to add too, which is during these episodes we also monitor any direct harm incidents that come through, just for assurance to the board, and we're not seeing, I think as you've intimated, it's probably longer term consequences opposed to direct harm at the time, but we do monitor that during these episodes.
Thank you. I think it's just important just to keep sighted on that in terms of what the impact is likely to be. My other question is around the medical agency locums. So it's good to see we've got some traction on that, we've got some work going on in that area. We currently have 30 agency locums, and I guess my question was, are the 30 related to vacancy gaps, or are there other reasons, as in sickness, cover, annual leave, etc., etc.? It's just to try and get a gauge of what these 30 are actually being, what are they covering in terms of.
So we only sign off agency for vacancies. And so, and many of these are long term, so they are individuals that, turning over, they are individuals that have been working for us for some time, hence why the idea to provide the exit plan, some of that is about providing people, persuading people to come substantively, versus also needing to think about our cohort of doctors and how we use them differently. But we don't sign an agency for annual leave, and we don't sign an agency for sickness.
Okay.
Yeah, can I just follow up on your question, Phil, because a lot of the 38, couple of lots of, which require radical change, I think service redesign and cost redesign. What are the timescales around that? And I just want to get a sense of that service redesign, that the sort of thing that may require consultation.
Quite lots.
Consultation with the public, because if we're going to radically change the service, we potentially have to consult the public. So I just want to get a sense of it, because that sentence there's a lot in there.
So most of the vacancies are in our community mental health teams, and as was mentioned before, the demand has hugely increased. So we're looking at reviewing how we provide our service. It's not something that needs major consultation, and it's more about integrating more in the community, linking in other changes in community transformation, community integration, and primary care, secondary care, neighborhood teams. So we have quite a few workshops planned for the next few months where everybody's join up, and that's actually helped us to recruit a few people into NHS contracts and reduce agency.
Well, we're not planning organisational change such that we will require consultation at this stage.
Thank you.
Okay. Couple more questions.
In the report, we make mention around keeping urgent care for the work that has been undertaken around the rostering. How is this actually being effectively monitored? Not necessarily just in that particular division, but it's probably a question, but across the trust, in terms of really drilling down to how effective are we utilising the rostering, which it's not just about savings, but also it dovetails very well with flexible working. And obviously the flexible working offer that we, that we offer to our staff, but also it's got a cost benefit as well. So I just wanted to get a greater understanding of what work is being done to replicate that across.
Patrick might want to start, but Lisa will also, because it's been a lot of work's being led by nursing.
Okay.
Yeah, but, I mean, I can just say in terms of the way we maintain oversight around the rostering. So we have the safer staffing group that does report both into QPAs and also into the people committee, giving sure in terms of where we are. We also have the KPI, making sure that the doctors are done 6 weeks in advance. We know that we're not meeting that target, and we receive reports on a quarterly basis in terms of monitoring that. So there is work that I'm sure Lisa will be able to talk about that's been done to improve that position, and we did see that where we have a real focus on this work, there is an improvement. So over the festive period, there was a real focus on using e-rostering, where the heads of nursing got together, giving assurance around rotas. I think that's been really effective, and now it's about how do we make sure that we sustain it from that side. So,
yeah, I mean, you touched on the different ways that we're monitoring the e-rostering, and part of this, kind of the granular detail of this, is the confirm and challenge clinics that we have with the matrons, the ward managers, and the CNNs who manage the rosters. And indeed, Casey actually, who's our safe staffing lead, is running and is extending the project around rostering. So it takes time to get this embedded in any organisation. You expect a year plus to get this re-embedded at that granular level.
Okay.
And then, of course, on top of that, dovetailing into that are the host establishment reviews that are also being undertaken at the moment. And I understand the third and final host establishment review will come to board in January, February of next year. Yes, so towards the end of the year.
Is that the length of time it takes to
there's several.
So February there will be another look in September again, there'll be another piece that will be done on all of the wards, and then we'll get the report that will take a view of having looked at all of those. That's the process.
That's not to say that decisions, if there's an urgency around a post isn't taken, this will give the board a full oversight of that review, that establishment review.
Thank you.
And I think it's really important that we do place an emphasis around the effectiveness of utilising this particular system. It's been around a very long time, it's not new, but it's just how the different divisions and managers use it. And the reason why I connected flexible working to that, because obviously if you're planning in advance, the resistance then to actually want to approve requests for flexible working, so I can plan way in advance and populate my rosters to fit in with the different complementary ways of working that I've got within the team. So there's lots of multiple benefits that can get to that.
Yeah, and just to add to that, Chair, myself and Richard, the Deputy Finance Director, have done some deep dives with some of the divisions, particularly the ones where they're in rostering, there's room for improvement, I'd say. And we found that with the flexible working, that some of the teams have put extra sort of shifts on there to account for the flexible working. So it's been really helpful to go through the rosters, to pull out sort of the good practice there, but also to put some challenging around, this is what the policy says, you need to work to the policy. So there's been a lot of rollout of training, the check and challenge. So I feel like we've really ratcheted up the work we do within rostering, because it is a system. It's a system that we use to do a really good roster, and it has a lot of benefits. So people are getting the right annual leave, people are getting the right breaks. It's a really, really good system. And we've got a dashboard as well, so you can have a look, on your ward, what your roster looks like. So it feels like it's really, really getting a lot more traction now. But we've got a lot of oversight as part of it, the safer staffing and regular reports, again, which Patrick says comes through committees as well. So, yeah.
Thanks, and thanks for bringing that sort of point about the rostering, about the multiple levels and the benefits. It's not just about the rota per se, it's also the planning.
Oh, absolutely.
The planning and training as well, managed to train can be utilised.
And annual leave, more importantly, regular annual leave.
Yeah, so good to hear that. Okay, finally, this isn't a question, it's just a note of, it was great to see in terms of the Barbary services, went to the Barbary, I'm hugely impressed in not doing any visits to anywhere, but they're doing some fantastic work, and they're one of the leaders in the country as well, so super proud of it. I just wanted to make mention of the user that was the positive news that was mentioned in your report. So thank you. So moving on to the BAF. David.
Thank you very much, Chair. I think the report is right. I'll just take the board through the areas of the report. The BAF is intended to enable the board to gain assurance and confidence that principal risks which are linked to the delivery of the strategy objectives are being effectively mitigated and managed in line with the trust risk management policy and best practice. It's also worth noting that effective corporate governance requires the board to pay much attention to risk and the BAF, just as it does to performance and finance as well. And it's important as well also to know that the BAF serves as an effective tool for board members to interrogate and assure themselves that the systems and processes in place for managing risk are robust and effective and fit for purpose. Then the rest of the report gives some of the updates and some of the feedback that we've received from the various board committees and what has been done around that as well. And then in terms of the key issues, it's worth noting that the BAF is a very dynamic tool. It's virtually changing. We are in the process of reviewing it and looking at how the presentation, its presentation, as well as also interrogating quite a lot of things around the BAF as well. So, and then we're also looking at the new strategic goals and objectives for the next year as well, which means that those will be fed through the BAF as we progress the piece of work around updating and reviewing it. What is requested of the board is, one, to note the content of this report, including the BAF, and also to review and scrutinize and endorse the BAF, its current form and structure, noting that it is a piece of work which is undergoing a lot of changes, and also to gain assurance as well that principal risks are being mitigated and managed in line with best practice. and the trust risk management policy. And the rest of the report sets out the BAP in more details. I'm happy to take questions, please.
Yes. Okay, can I open for any questions in relation to the BAP?
Really helpful report, David, thank you. Just one question, so in the under 3 at the very end where it talks about the people committee asking for that piece of work to be done to review the dates and the fact that it's been taken forward, I just wondered if we can have a time frame when we see that as being completed.
We intend to get that by June, and then it will be fed through into the strategic board development session, because the BAP is owned by the board. So the board will look at the template that the people committee have suggested, and they will say, okay, that's satisfied with the correct presentation, or they need it to be tweaked left and right, and then once the board approves it, ratifies, it becomes like a template for other committees to.
So I wasn't sure the response question was on sort of due dates of the actions or the change of the BAP, the proposed changes to the BAP. So my point was around just for clarity in terms of the BAP around the people community, those two, which I think, although we presented to the people committee, we will continue to run with the current BAP. I think just to emphasise what David's saying, and I think in terms of the dates element, I think what's in the BAF is the bit around when do we, in terms of the days around making sure the controls are in place, and then thinking about when you bring the assurance. So I think having clarity around that is helpful. Potentially the changes in the template could help us in being clear around that, because some of the days that were sitting in the back for, say, April, it was giving the assurance that the controls were in place by April, but not necessarily that you would then gain the assurance. So I think it's just the level of clarity we need to have in the back around that.
We were talking about all the bump session, I think in September, so that next situation to go through, so that's the time.
Okay. I think just the specific question around the actions. We did review that the following day, post the People's Committee, the BAP leads for the people that work for. They did look at the BAP and they did stagger the days now. So the days are now staggered right up to the end of the year.
Okay.
So that will be fed through into this updated version. So that's done.
Right, because some of the due dates of past documents.
No, for the People's Committee, the query you raised was around the days or in April.
Yeah.
The challenge was, is it realistic? So I took that back to them. They said, no, it's not realistic. We'll now look at more realistic dates. That has been done. But the other piece of work was around BAP owners looking at their risk and some of the dates, actions that have been out of date. And they requested for the extension of the dates. That was approved by both committees. That those new dates have not been captured in this version of the BAP. So I'm just providing a summary to the board that these actions have got their dates changed in line as board committees had approved. So the details are in the BAP.
Correct.
So, just one last one, specific one. One of the risks that's gone up in BAP 02, which is about risk of pension harm. And just looking at the detail, it's actually the current risk is having inherent risk, and I don't understand that. So where we start from and what the inherent risk in the system is, we're in a different place. We're higher than that at the minute, David. I don't know if that means it's a typo or it's an oversight. But I'm bothered that we're not necessarily going into the detail on the individual ones. So I suppose it's just a query to come back on. It's about the level of robustness that goes into the review. That one looks like it's worsened against the inherent position. I can understand it worsening, but not against the inherent position unless something it would suggest something fundamental.
So we could ask Keith first.
Yeah. I think the BAP's already to it initially started at 12. These are the piece of work and some of the challenges around some of the areas
that we thought were doing well.
No, I understand that.
Yeah. The point is though, that means the inherent risk must be wrong originally. So what we've said is the inherent risk without doing any changes, the changes we made effectively made it worse. Not it's worsened, but effectively we worsened the inherent position. So that's suggesting either inherent good.
Yeah. But yeah, if it goes back to.
Thank you, President.
Yes.
Yeah, I've got more sort of, more detail in my, so this is something that we didn't have the time to go into in QPS, but I do want to ask about it because it's, I think it's important. But for BAF 06 QPS, we want to subscribe to potential failure to implement the, sorry, QPS are far one before it, sorry. But certainly referring to roots and communities and tackle health and equality. So I think that's something that's important to us, important to the piece of RCS. So looking into the detail of it, I don't want to take you to details. He talks about that we may not be engaging directors or communities properly, and in particular, he talks about divisional inequalities plans and specific questions. Do we have no divisional health inequalities plans? And if we have, it'd be good to share some of those at QPS. So this will.
I think we'd also, so I think we do have those, and I think we'd also agreed that we wanted to do a strategic session in May on health inequality, so that would cover some of what you just asked. That's not to take away your ask about what's going through committees, but one of the things we might want to consider at that development session is what ought to go to what committee.
Just a general observation. I just wanted to say, I think we'll all agree we're in a far better place than we were this time last year. So, thanks to David and the team for getting us here. And I think, we're getting to that point where this document starts to become a little bit more dynamic. And to Dave's point, I think we do need to be very cognizant of the fact that when does the risk actually become an issue, and what is that chain of escalation then that needs to then happen, and where does that occur, and what's the process? And I think that then moves into the next agenda item. I think the sort of risk register in terms of how the two work together. But yeah, just generally, I think we're in a far better place than we were this time last year. So thank you.
Well, I'm glad you mentioned that, because my next question in relation to the BAC was really centred around the committee chairs, and actually asking the committee chairs in relation to, now this is actually a feature on your agenda, how effective are you utilising the BAC to drive the discussions that you're having within the committees, which is good.
I think we're getting better. This is from an FPP perspective. I think we're getting better. It's maturing. I think BAF being at the start of the agenda rather than the back end conversation is a step forward, and that's how it should be. But like I say, there's still more work to be done. And as chairs, I think we're triangulating between us. In terms of the conversations that we're having at our respective committees as well, but I'll let our colleagues comment.
Yeah, I think we're starting to use it to focus our agendas and what we're looking at in terms of the detail within committees. So I agree with Al's comments. We're working on it.
Good.
It's useful. I think it's good that we've got the deep dive sessions in between to make things a little bit more positive as well. Just gives us that protected space.
Thank you.
From the committee perspective, I'd say that so I can see that committees are reviewing the major areas of the BAC, as well as the research. So, and also we received a report from internal audit which suggested that our ranges of reviewing that has improved compared to previous years. So there's a degree of independent assurance from that point of view. I completely agree with how that really much better place than we were before. It's also, I think, where we've shone a light on it, and we can see where the areas of improvement and making progress. So that's that gives me a degree of assurance from the committee perspective.
Brilliant. Thank you. Thanks.
But on our BAF, we're not currently reflecting our the other committee that we're on, which is the Caring Minds Committee.
Caring Minds.
Yeah, we're at the moment not reflecting, particular with this, so we think about assurance on that, on the BAF, which you could argue is maybe a kind of public BAF in this public comment. but we are an overall board. So I think that's something just throw that in there, but I think it's something worthwhile consideration.
Yeah.
Dave, just on that, the BAF is based on assurance against non-achievement of strategic risk. What the point is written there for is there isn't strategic risk relating to the trustees of the charitable trust funds. So that's what would need to happen for it to come on there. So it's not driven by, there's a committee, it's driven by the fact there's a strategic risk. So we just need to be thoughtful about what it will be on for in terms of that.
Great, thank you. That's very, very helpful. And it's great to see the progress that we're making in relation to the VAF. David, over to you for the corporate risk register.
Oh, thank you very much, Chair. Thank you for us read. A few things just to note that the corporate risk comprises the high level operational risk. These are risks that score 15 and above in the divisions and the services and departments that have been escalated through the governance route or management route and have been approved by the risk management group for inclusion on the corporate risk register. It's very important that we really define that and set that content because sometimes they get confused with risks from the corporate services, corporate areas. So these are high level operational risks that we have here as well. The purpose of it, the part of the CR coming is to enable us to read it alongside with the BAF to see how they dovetail, how they inform and feed off each other, and also to see what learning we can pull from both tools as well, and to see the symbiotic relationship between them, and also to do some triangulation and joint and shared learning from these two tools, which are very intended to provide the board with a lot of assurance that the risk management systems in place are robust and effective and delivering what they are meant for, both in managing strategic risk and high-level operational risk as well. I think it's one sets out the structure of the corporate risk register. It's worth noting that this is still a process, it's a baby process in the infant stage. We are still getting the divisions into the space of escalated risk through the governance process, through the risk management group for inclusion here. We've got one division has done that. And then we've got some of the risk from corporate services, finance, and workforce and strategy. So this is the process, and we intend to get them escalated a lot of risk to come through so that we're able to shine the light on some of our high-level operational risk and focus the discussion and decision around them as well. Happy to take questions on the CR.
Thanks, David. Are there any questions?
Well, just a very, very quick observation. I know we've got one finance risk here around inability to deliver saving. I'm just wondering, going into next year, the level of capital constraints we've got and our ability to manage our estate in an effective way and keep it, keep it as good as it can be is a huge challenge. I'm just wondering whether that's that will impact our people, it'll impact our ability to have a safe environment for our patients. So I'm just throwing it out there and just consider whether we need to have that.
So we do look at the capital review group and work around that. I think there is a risk element. Let me just tell you what the score is on it.
Yeah.
It might be just not friendly, but we put a work around that.
Any other comments in relation to corporate risk register?
So I'll make a comment that it's evident here that they're starting to use risk management, they're starting to obviously some of these. So I think it's good that as a board we're starting to see the scoring of the risks, the higher ones from an operational perspective. And there are a couple of them that will score as 20, which I think just focus our attention towards not what those are. So two things, how long they've been scored at 20 and also what are we actively doing with that. I don't think that's what it needs to that question. Where the board, excuse me, where the board doesn't want to get to operation instead of operations. It's more about, so those that are scored now, what's that process of doing something about it? There is highlights of the risk management group, with also how they follow that. So, and as far as that's the nub of it for me. It's how confident are we in our process with it. So.
Yeah. What's the process then, David, of the risks at each sort of 20?
20, yeah.
Do they then move to the back?
No. So a couple of things. One is that some of the risks are quite historic. They were identified in 2015. We are in the process at the moment with the teams having discussion around how do we redefine the risk to reflect our current performance and current challenges.
So it stays on there then?
Yes, so the teams are in the process of doing that, which means we will be able to redefine the risk and the start date of the risk may change and discuss as well. In terms of the risk that score 20, they will remain 20 until the time that there is sufficient evidence that they be mitigated sufficiently to reduce the score. And then the teams can suggest the reduction of score. So the risk management group for approval.
It's good to hear that, sorry, Wednesday.
Just to be specific around it, so as I said before, the board assurance framework is about risk and strategic objectives, so i.e. top-down reviews. The corporate risk registers, where you record ones that are coming through, they will never go on to that. What you'll do, or you'll need to do, is review the strategic issues that you've got and look at, is it covered in one of those, or are we missing something in the process? But they are two separate things. You use to check out each other. You don't know how to do what the might have misunderstood.
Yeah, I think it's just around how we avoid duplication. So I can really see that there's two there that talk about RMNs and how do we ensure that divisions are putting risk there, then we're clear around how we provide assurance into the communities, so we're not seeing 4 or 5 risks that are just similar. So it's something that we can pick up.
Yeah. That will go within the context of risk aggregation. So we have risks that are escalated from 3 or 4 around the same story. How do we aggregate them while still maintaining their identity, such that the divisions don't lose sight of what they may be doing. But we're able to tell a single story through all of that.
Yeah, just go back. So on that summary risk table, it'd be helpful, I think, if we had a indicators when this was raised, so we've got indications to how long it's been around that particular list. That would be quite helpful because it's a recent one and it's 20, then we wouldn't expect an action plan. Whereas if it's an older one at 20, then think about actually what that would be doing. So I think that would be quite helpful.
Definitely, yeah, that was the point I was actually going to make, particularly in relation to the historical risks that have the corporate risk register, because sometimes I've been on the trusts where they've been on there for years, and it's just like understanding the review process, understanding why the risk isn't reducing, what's the plan, etc. So that was well made by us. So thank you for that. There's no other questions in relation to corporate risk register today. We'll move on to QPES. Sean, forward.
Thank you, Chair. We've had 2 meetings, one in February and one in March that I'm reporting on, and there are some commonalities across those committees. I know you've had the report, but I'll try and highlight some key pointers. So staffing remains an alert for us, sort of partial assurance. Although we've had some positive recruitment strategies, events, staffing levels across the trust are still a cause for concern and are recorded on the risk register, and work streams are in place to mitigate against all those risks, so we're assured by that. And the trust is continuing to use the mental health optimal staffing tool that will, over time, give us a clearer picture of how we support that acuity across the inpatient areas in particular. We had concern around some transport issues, so there's been a number of concerns across our system regarding the safe and appropriate transfer of our service users. We're reviewing contracts and policies, and also there's work being undertaken with our systems partners as well, so that's an ongoing piece of work. As we've just talked about, the risk management group has been re-established within the local divisions and taking responsibility. So we're pleased to see that in place. We continue to have updates on our progress in relation to the CQC inspection that took place in October last year. And it was confirmed that the trust has delivered against all the actions following that receipt of the Section 31 notice in December 20. and therefore the trust has been served with a notice of proposal to remove those conditions, and that's really positive. We've seen some improvements in pharmacy staffing, and that has had an improvement on the services that we have received in 23, and we're expecting to see further improvements in our pharmacy services this year. We were assured that our Learning from Deaths group have developed links with safeguarding, and we've got they have scheduled a deep dive in line with the patient care and race equality framework, which I think will be really important piece of work. What else? Oh yes, we in February heard a service user story which raised concerns around our falls policy not being adhered to, and the story we heard sadly had a long-term impact on the service user and are following the fall. And the incident highlighted the need for us to have much more clarity around our locum doctors and their responsibilities and their accountability. And we were assured that we've learned a number of lessons. For example, there's going to be further training and development of an induction package for local doctors to mitigate that. Coming on to the March committee, we were already made aware in the previous committee that the measles cases in the city were increasing. We actually had a confirmed measles case in January on one of our inpatient units. And there was an immediate isolation and contact tracing and deployment of PPE. Staff with unknown immunisation status were temporarily restricted from work. And actually we were really pleased with the response of our infection prevention control team. And we didn't have a spread of the measles. So it was a concern, but we managed it really well. We did have to feed back our concerns to another organisation from which the patient had been transferred to us from another hospital in our patch. So we followed up on that as well. So there's some learning for themselves as well in relation to that. There are concerns around our assurance in terms of staff vaccination before starting a job with us in the trust in relation to both MMR but also hepatitis B as well, so we're working on that. IPC also had some concerns about our level of non-compliance from clinical teams to submit the monthly audits around infection prevention and control, and there's been a meeting held with the head of nursing to look to how we can increase that compliance in those teams. You're probably aware that we had the Health Watch survey reported back to us, and we noted as a committee the significant increase in referrals to our services and the ongoing impact from COVID, whilst our services are continuing to develop and improve and manage the increasing demands of over 10,000 extra cases. I think that's right. There was a detailed discussion in committee in relation to issues we had with the report and the sort of lack of understanding of mental health and our divisions and services linked to that. And we were assured that communications are ongoing with Health Watch to strengthen their mental health understanding and our partnership arrangements with them. And then finally, the CQC update from last month. There have been recent queries received from the CQC, and they've been focused on Rayside, cilantro, and the acute inpatient wards. And we are assured that all queries have been sent to the senior leaders in those areas to enable us to have a full response to the CQC. But the concerns inquiries were related to staffing levels, clinical and nursing care provision, management support, management of serious incidents. So I think that's all I've got to probably highlight from those.
Thank you. Are there any questions for
Just check. I don't think you mentioned the capital plan.
I didn't, we did, it's in the,
I know it's in the report, but I think we just need to just note it. That was, as I understand it, endorsed by.
Yeah, we did.
Thank
Thank you, yeah, we did.
We'll come back to it later on.
Yeah, we did, thank you.
No problem.
Just a, excuse me, just a question on the transport issues. I know that's been flagged twice on both committees. Whilst there's a review of the contracts and policies and processes, what's in place in the interim then to assure that we've got a safe and appropriate transport of our service users?
Yeah, we do have a contract with the provider and working with the ambulance service as well. There's a small group looking at that to making sure that, you know, transport is timely. I think our challenge is mainly out of hours when we are moving people from, for example, from an A&E department into a bed, or potentially if we have to place someone out of area. So that's more of the challenge, but we do have an existing contract with the provider, but looking at a wider offer across our system, working with colleagues as well.
Can I just add to that?
Oh, sorry, yeah, just to add to that, because we have seen some incidents related to transport, we've also made a proposal for a safety summit looking at those groups of incidents to see if there are themes and trends, etc., that we can pull out of that we can act upon from our own perspective as a trust and from a learning perspective and from the provider. So that is also underway at the moment.
It was discussed at the Trust Clinical Governance Committee yesterday, and there is a standard operating procedure that was submitted for going through the process, so we're looking at that. But in addition, really credit to colleagues who participated in system conversations, because the West Midlands Ambulance Service have raised mental health patients from category 4 to a category 2, which will really, you know, make us monitor the response time from the ambulance services as well. So there's a lot of positive developments in the last few months due to the conversations in the system.
That's great. Thank you. Just one comment from me, really, just the point that you mentioned around the Health Watch survey. I did have a meeting with Richard Burton yesterday, and I know that Andy Cave and Vanessa did read, and I raised this particular point with him, which he accepted with a bit of pushback, but he accepted. They are our critical friends. They're there to hold us to account, because they're the voice of the patients and service users in the community. But at the same time, as Rashid was saying, they're also there to educate as well, and to pass on information about what provision is available for people who want to access services and how they can access them. One thing that we agreed is that they got a board meeting in Health Watch in June or July, and they said it might be beneficial. We saw Vanessa and ourselves and partners going on as well, just to talk to them and just raise some awareness about our service provisions, so that they can get a greater understanding. It isn't necessarily about you got your information in the survey wrong. It's actually you feel like you benefit from having a greater awareness of our service provisions, so that you can actually communicate that information to those who have to come in contact with you if they're raising concerns about access. So just wanted to point that out as well. Okay, brilliant. So moving on to Capital Committee report. I'm not sure who's doing this in order.
This is from our People Committee on the 20th of March. I would accept my apologies for that meeting as chair, and I'll chaired in my place, and I'm sure we'll step in if there's any stand points. The committee wishes to let the board of a couple of areas around increasing staffing. So there's been a 3% increase in whole-time equivalent staffing. There had been this shortfall. This is a shortfall on what we was expecting of 6.8%. Considering the growth plan for the new financial year, this would be a significant challenge. However, the committee is still ambitious in terms of the targets for 23-24 being achieved. There has been a recruitment on international nurses. The Trust has welcomed 32 nurses to the organisation. The plan is continuing to be developed to achieve the full target by the end of the year. There's also been new data collated around flexible working in regards to an increase in requests being made, and there's also investigation in terms of how those requests are being met in regards to the Trust, and we're looking at that going forward. There's been some challenges in regards to the spend still around bank agency. We have made some improvements and still ongoing work being done around that. Sickness does remain a challenge for the Trust, and I think last report we mentioned that there was some barriers with regards to occupational health, and we're still hoping to get some updates in regards to how that has been addressed in regards to staff coming back to work from long-term sick. There has been a reduction in turnover in January, and exit interview data is being analysed in terms of how we can identify ways for improvement around staff exits in the Trust. The committee was assured around its involvement and support for staff that were observing Ramadan, and we had a positive staff story from a staff member that was shared his experience of observing Ramadan within the Trust and the support that he received in regards to staff that were observing Ramadan in regards to opportunities for them to have access to spaces for prayer, and just being compassionate in regards to the observations that were being undertaken by staff that were observing Ramadan during this period. The committee was also assured around the safer staffing report, and there continued to be highlights around progress around MHOST and new rostering plans, which has already been mentioned. The committee was advised of the staff survey, which Patrick will be presenting on, so I won't go into too much details around that. There were no sort of areas of significantly worse areas in the staffing report, and we started to see some green shoots appear from the work that's been done around the people committee in regards to the staff engagement and staff feedback from the survey, which Patrick will read feedback on and present. I think I'm going to end there. Any questions?
Yeah, good question. So, okay,
So just first, I think you said there was a shortfall in recruitment against what was expected. This says it's the other way around. So actually there was greater recruitment than we expected. So I did want to ask just a clarification on that, following on from that. So that's across the piece. I know that there's quite a significant difference in variation between the different areas. I just wondered, does the committee look at that variation in the different areas? Because that can mask an overall 7%. I know that in acute and urgent care, for instance, it's less than 3%. I think it's just important we've got that understanding at the granular level as well as the overall. So I just wondered if that picked up as well.
Yeah, so in terms of the reports into the committee, what we've been focusing more on is more reporting by profession rather than by division, specifically around RMNs, given that that is the area where we have the biggest deficit. We have the dashboards that's available where you can break it down by different areas, different grades if you want to look at it. But it's something that we can consider in terms of divisions. We do that in other areas, for example, sickness, we report that by division. In terms of this, the focus of the committee is mainly being by profession and mainly in terms of.
The only reason I come on to when we talk about the trade fraud report, just making sure that the right level comes through. So there's a query with FDP, I'll come on back onto later. It's just making sure that's also seen. It's both, you've said you look at the professions, it's also going to be a service to things, and that's what I'm saying.
Yeah, I was going to just clarify the point around the full-time equivalents. It was a positive trend from that perspective, and then seeing the turnover reduction as well was good. And I think the challenge, being chair of FPP, was how does that manifest itself in terms of the sort of the opportunity and benefit from the financial savings as well. So just trying to triangulate that. So from that perspective, and I think just one other thing I wanted to say, the presentation about Ramadan, it was really great. I think in terms of busting some of the myths. And also, some of the stereotypical questions that people ask. It was a really real eye opener, certainly from my perspective. So thank you to I can't remember the gentleman's name who came along to present. So thank you for that.
In terms of Paul's point around people and finance, so it links into something that Vanessa mentioned that she's been doing with Richard around deep diving into divisions. So what we had seen is that as much as we have recruited more staff in the organisation and our retention has improved, we're still seeing an increase in bank usage. True. And the main reason for that is acuity, which means a deep dive into understanding what's driving that around the activity, and the continuous usage of bank means that we wouldn't see the impact from a financial perspective. So I think that's the work that we need to continue to do to make sure that, yes, we're having those numbers. And given that our workforce plan last year was focusing on having that growth and the RMNs that we referred to, we're going to have a very different challenge moving forward around what that focus should be. We can't continue to just grow our workforce. We've got to be a bit more measured and specific about where we want to see growth.
Just on that point there, in terms of the acuity levels increasing, so that then equates to requiring more staff around ops and observation. So it would be a 3-to-1.
Yeah.
So you're increasing the staff, so you'd have to go to temporary staffing or
Yeah, or staff.
Hopefully.
Yeah, or permanent staff
Or
will
permanent
potentially
staff.
do an additional shift on the day or anything. But that's reviewed twice daily as part of the safety huddles that the wards and the teams have. So that's reviewed.
What we're expecting is that gets reflected in the post work. So
Yes.
doing the post work is so to look at actually what does further needs, what are the clinical interventions, what's the need in the ward, and determine what the level of staffing should be on those particular days, and that will be reflected in the stuff.
Yeah, and I think also the work that we're about to pilot in CUTE around that's referencing your paper actually around something that I want to bring in from the previous trust, looking at the top bank spends and looking at deep diving into their rosters, acuity, and seeing if there is work actually, other work that we can be doing to support these areas. It's going to be very interesting to see the information that comes out of that.
Just an observation really, just mindful, like the first two bullets, whether they are an actual alert or if they're just kind of advising us to just be mindful of that. So that, the target of 16 international recruited nurses haven't been reached. They're only welcome 32. So for me, I didn't equate it to an alert per se, or more of an advice.
It's just a quick one really, being mindful that some of the staffing challenges are increased by the environment, the inappropriate capital that we find ourselves with now. Is that reflected in the measures? When we measure the need for increased staffing, are we also recording that if our environment was different, better designed, that we would need to do this?
I don't think we're recording that. What we are doing is identifying the estate that we think isn't.
But we're not sort of quantifying how much it costs us on a monthly
Well, I
basis.
think it's difficult to.
It is, isn't it? I appreciate that.
Yeah, so if we look at the work we're doing around establishing what the staffing models would look like in the new Highcroft, actually we're needing to think differently about what the model of care might be as well as what the environment.
Yeah.
So it's but we might at some point be able, once we've bottomed that out, to be able to do that comparator.
Yeah.
But that will change as soon as that's built. That will change.
Yeah. Thank you.
Thank you. Okay, well, we're going to move on to the staff survey.
Yeah, thank you. So first of all, I think a huge thank you to the colleagues who completed the staff survey. We had 2,393 colleagues in the organisation that completed the staff survey. That equated to 55%, and compared to last year, although it was 55%, we have certainly seen 163 more colleagues completing the staff survey. A huge thank you to colleagues who really worked together to ensure that we see that that increase, and also to John Travers, our lead for staff engagement, who has been going to different teams to encourage them to complete the survey. And that means as well that we had 112 teams that received a localised report compared to 92 that we had last year. Mm-hmm. So that means colleagues had 11 people who have completed the staff survey who have their localised report. Our bank colleagues also completed the staff survey. We had 253 who responded. That's equating to 33.64%. I am told that's quite high compared to other organisations, but we've not had a breakdown in terms of how we benchmark against other organisations. I think this is the second year the bank-only staff survey is being run, and previously we were doing our local staff survey of our bank colleagues, so we're probably just ahead of the game. That's why we have a high response rate. So in terms of where we are across the staff survey, in terms of some of the key questions around engagement, first one is around recommending the organisation as a place to work. We have seen a 5.8% increase in the number of people who are recommending us as a place to work. And when we look at ourselves locally, in terms of the Midlands, we were second in the Midlands and sixth nationally in relation to the improvement that we've seen in that score. And also we have 55% of our staff who recommend us as a place of care, which is a 4% increase from last year. So, but there's still a lot of work for us to do. I think we are seeing that improvement in place. And also just to highlight, we have the People Promise, where we're measured against that nationally, and you can see in the presentation how we feature since 2021. You can see that we are improving year on year on those domains. Which I think is testament to the journey that we're on as an organisation to really focus on these things. And the thing that has improved the most is the one around we work flexibly. You'll be aware that we introduced the flexible working policy in the organisation, and there was a reference in the People Committee report in terms of the insurance that we're starting to build. building the data and how many people work flexibly in the organisation. We've been running seminars and workshops for staff. We know that there's still work to do, but people are starting to report that they're seeing improvement in working flexibly. So it's really good to see that we are making progress against all of the things in the Future Promise. There's also a comparison here in the slides around how we compare to system partners. It's just to give you an insight as well into that information. So I'm not going to go into a lot of detail on that. In terms of the questions themselves, we have done significantly better on 63 questions this year, and no significant difference on 33 questions, which is really good. Again, demonstrates this similar trend against the People Promise themes and those questions, which are quite detailed, because in terms of the People Promise, it's a combination of a number of different questions. So being able to get into the granular detail of individual questions and whether we made an improvement or not, I think is really important. And just moving on in terms of where we have seen some of those improvements is around, just to pick out a few, where there are opportunities for career development within the organisation. Starting to see us going in the right direction. However, again, still quite a bit of work for us to do. Also around appraisals, we know that that's one of the areas where we've been providing assurance, working on it in the organisation. We've listened to a number of different challenges and concerns that the staff have had over time. Although we're still not in the place that we need to be, but we're hearing in the staff survey that that's one of the areas that people are seeing improvement. Just moving on in terms of other areas that I just want to flag for you. 99% of our colleagues know our trust values, and given the conversation that we had in the morning, again, to highlight that we need to do a lot more work around making sure that those values are truly embedded in the way people experience care within the organisation. However, it is good to see that our colleagues recognise and understand our values. In terms of some of the areas I just wanted to highlight as well, is some of the divisions that have made really good progress. And just to flag one area, which is ICCR, where we have seen we've had the most improved directorate year on year. Last year we did run Listen Up live sessions for them to share what they've done within their division. We will be doing the same this year, working with different teams that have done really well, because we know that when there's local ownership of the staff survey, it makes a really big difference. And the fact that we've got 112 this year compared to last year means that there will be a lot more focus and more teams to be able to do that. So just to flag in terms of some of the areas that we need to really focus on and do a lot more on. Certainly, people are reporting that they are working over and above their contracted hours unpaid. We need to find ways of how we can manage that, as it's not certainly sustainable. People experiencing bullying and harassment from patients and service users is another area of focus. People experiencing discrimination from patients and service users, and also taking a positive position on health and well-being. Other areas from a clinical perspective around reporting errors and near misses, and just to pick out another example, around immediate managers gives clear feedback on my work. So although we have the appraisal process, we have support for managers in terms of line managers training. There's certainly a lot more that we can do to ensure that people feel valued by their line managers. I also wanted to highlight that for the first time this year we've had a question in relation to unwanted behaviour of sexual nature from our colleagues. Our score demonstrates that there's a lot more we need to be doing as an organisation to respond to this. We have signed up to the Charter for sexual abuse and harassment, which will be bringing assurance to the People Committee and to the board in the coming months, clearly to outline what we're doing against the 10 points set out within the Charter. And I also wanted to highlight to the board that we've tried to triangulate some of this feedback with what we've received through the open conversations that we've done through the RCB. And you can see as well that the subject of discrimination, bullying and harassment and being inclusive within the organisation does feature as a key topic that came out as part of the big conversation. And you can see that our organisation is the second highest in terms of participants in that process. So the next step for us is, first of all, disseminating the staff survey to all the different teams. We have a number of work programmes that are already in chain, which I think we need to continue in terms of sustainability, because it's demonstrating that there are some things that we're doing in the organisation that are working, and we need to continue with that. We have corporate support that's available, and we're now working on business partnering model through the organisational development and equalities lens, and that's detailed in the report, where each division do know where they can seek support if they need that to be able to move forward with their plans around the staff survey. So I'm going to pause there and take any questions.
Thanks, Patrick. David and John.
It's not a question so much as I think just an observation. It's really important to get the right balance. We have got further to go. But looking back 4 or 5 years, we used to have really poor responses, among the worst in the country. I think we need to recognise that actually significantly better than it was previously. I think we need to recognise that all the time. And also where we stand in the economy is also really, really high. So clearly we are doing things right. I think it's about how you celebrate without going over the top about it. It's really important, because we heard earlier on this thing about you've got to watch what you say. Yeah. I think it's really important to get the balance right around there. And I think it's right to pick out ICCR, but there are others where we have got this again divergence between different teams. It's really important to understand that as well, because you've got some parts where things are going really well or moving really well, and others we're not getting that same. We're getting through both. And we appreciate the positives and make that better, but also really do more nuanced or focused around those that are different.
Yes, and machine.
Yeah, firstly, just to reiterate that, I think I said it at the People Committee. Whilst this isn't the victory parade that we don't want to overly celebrate, but I think in terms of where we were and where we are at today, I think we should use that in our messaging in a very positive way, and how that then contributes to the overall organisational health of the trust. So I think we should be positives here and sort of be very forthright in what we've achieved. My question was really going to be, I know there's a table here that sort of compares us against our system partners, but what trust is the poster trust nationally for mental health and how far away are we from aspiring to be the best? I think it'd be good to have that sort of comparison.
So we're 31st out of 51.
Sure.
That's in the.
Oh, right, okay.
Overall, on very particular schools, they look at in that context. And we've certainly spent time talking to those organisations that have consistently stayed in the higher echelons. I would like to think that what we're doing is reflecting what we're doing everything on around cultural change and around valuing those valuable pieces. And so that's where I think the work that we've done to do that comparison. The point I wanted to make was I think that we're definitely in a space where actually this is an opportunity for us to do internal appreciative inquiry, because actually the most important journey is the journey that we're on, and not all of us are on the same path, that pathway, which is the point that David's making about the differential. So what is the appreciative inquiry? Last year we recognised that ICCR, who in the year before had done more work with doing work with individual teams, has managed to get a consistent improvement. And so that's a really key piece for us, is how do we support all of the divisions to get into a situation where local teams are able to have their own conversation about what does it mean for me on a day-to-day basis. Specialties is another directorate that made improvements this year by adopting that in a much more prolific way than some others may have done. So I think that, we absolutely need to celebrate those people who have embraced recognising the culture change that we want to make. There are 4,500 of us in the organisation. The staff survey is not just about the experiences organisationally, they're the day-to-day experiences that people have. And so every single one of us have got something to contribute to that. And it's really clear to me, given these results, that many people have had that reflection, have utilised some of the tools and techniques that we've made available around thinking about what does it mean to be an active bystander? What does it mean to be anti-racist? What does it mean to be compassionate? And I think that's the thing we want to celebrate and we want to thank people for.
If I may just come back on that, I absolutely agree there, Roisin. I think the other thing maybe we could look at is a comparison with our regional partners, mental health partners, particularly in terms of, the sort of almost the overlapping demographics, between Birmingham, Solihull and Coventry, Warwickshire, for instance, around the country, and maybe, there's a patient cohort that probably moves across those boundaries. And then, with my sort of my business hat on, comparing us in terms of a trust that people would want to come and work at compared to some of our competitors. I hate to use that word, but in sort of my everyday parlance, that's how I would look at it.
So we're the second most improved in the West Midlands.
Yes.
So again, so that's sixth overall for mental health trust in the country and second in the Midlands.
Going to go to Monica Jones.
I agree with what everyone said previously about the fact that we need to, celebrate to a certain degree the direction of travel given the improvements that we made. But it's really interesting to see that on the slide where it talks about areas of focus, one of the lowest scoring areas was if one of their friends or relatives needed treatment, they wouldn't be happy to refer them to our organisation. And I think that kind of resonates with what Claire was saying this morning. So despite the fact that 99% of our team know the values, I wonder whether it's a perception that those values only kind of are applicable amongst the team setting rather than reflected to service users as well. So I think obviously there's some work that needs to be done in that area, but that's quite a stark, in my view, quite a stark feedback in that actually it feels like our teams know there's something wrong there because they wouldn't refer it, wouldn't refer their friends and relatives as well. So it's just something to consider.
Good point, actually, raise there.
So yeah, so appraisals. I think there's a lot more work to do with appraisals. Really, I think Becoming having British phrases, I think, so we feel more recognised for where they do next one. So I know we're doing well on the second basic period, that sucks in the first, in a sense, being expressive there. I think flexible working is a good thing, but also just linked to that, or related to that, we've got 34% of our staff are working additional paid hours a week, so we've just got to do something about that, because otherwise people get exhausted, tired, burnt out, and really we can't afford for that to happen in a way. But for one individuals and also for point careful for service users as well. So I guess, I mean, it's a great platform for us to build upon. It's about what's our next step, really, I think. But I'm really positively encouraged, because the previous 3 years of the trust now, and I remember thinking, staff servicing, like, oh, okay, for another year, oh, okay. And this year it's really good that all the efforts are done from the exec team, the staff leaders out there are starting to make a difference.
I mean, it's the day-to-day experiences of people that are making the biggest difference. So it's those 4,500 people amongst those that have chosen to acknowledge that actually, being compassionate, being inclusive, and being committed is something that actually brings benefit for them too.
So we've got targets on the appraisals happening up, and are we going to make them a bit more challenging for us, or straightforward? I'm just thinking of a key area that we could just have a degree of focus on, simple to manage, simple to monitor.
I think the thing about appraisals is it's not just the doing of it, it's the experience of
Yeah.
it, so, which is what this is telling us. So it's that bit about the meaningfulness of it.
Yeah, it gets picked up on the
Yes, and just adding to in terms of the values work, it's just also about building on not just knowing values, but also the lived experience around values as well. So are we embedding living values across the trust? That was one of the things that I was just quite mindful of. The second thing was that around the areas of improvement, there's red flags for me in terms of staffing and burnout, even though they're working additional hours. So there's something around control mechanisms around staff doing additional hours, and actually that rest and respite period that Vanessa talked about in the host. Some of that might be captured in that space. But 65% of staff being burnout is a bit of a concern. And then the other thing is around the question that's been introduced around staff that have experienced unwanted behaviours of a sexual nature. Is any of that being captured in Freedom to Speak Up or any of our network services? Is that information or concerns that have been raised in other areas as well?
So I think it's one of those things that we need to, really be communicating, an area that we want to make improvements in. So there isn't anything coming through thematically from that Freedom to Speak Up on this at the moment. That doesn't mean that, it clearly doesn't mean that it isn't happening in what the survey says. So we need to really promote that actually this is an area that equally and other areas can be utilised for as well. I mean, the same, I don't think we're getting it on Dotex, we're not getting it on eclipses. So again, we want to promote the reporting.
Yeah.
So of course, once we get the reporting, we're much clearer about where it's happening, what we need to do about it.
Great, thanks. I won't take any further questions on the staff survey. Just to add, similar to what Dave said, actually, I think, believe when I came to the trust in 2019, the results of the staff survey, I think the take-up was 13, very low, 30-something%. And I was really, and I just come from the trust where it was 60, nearly 70. So I was like, wow, gosh, there's a lot of work that needs to be done. It's not just about numbers, actually, it's about our staff experience of working at this, at our trust. And we are still on that improvement journey. We've done a lot of work, but it's fantastic to see the green shoots. Just missed that target at the top 5, top 6 most improved trust. It is worthy of celebrating, but not as well said, bringing out the parade, because we know there are a lot of other staff members who won't identify with some of the positive results that have come out from it. But the more that we actually talk about it, and also the next steps, localise it as well, the more that we do that, then hopefully we will continue to see improvements. And that's what we want to celebrate, is that there has been an improvement in, across the board in some areas. And I think you reported as well, Patrick, that we haven't actually seen a dip in certain areas. Maybe we haven't seen a shift, but definitely haven't seen a dip, because that would be even more concerning for me if that was the case, reflected in the staff survey. We also have the full survey, which comes out mid-year as well.
It's on a quarterly basis.
On a quarterly basis as well. But we've got to continue on the improvement journey and not rest on our laurels, so to speak. And I know that we're not doing that, but it's just worth mentioning. Okay, so if we can move on, and if you can just pull out the key salient points for us in the assurance report from FPP.
Yeah, thank you, Chair. I'll take the report as read. Just to bring out the salient points, as you say, Chair. We were assured that our year-end position, posting a surplus, is a good, positive position. Notwithstanding that a lot of our savings were made in a non-recurrent way, and I think going forward that's clearly not sustainable. I think something we talk about on an ongoing basis. I think the committee was assured around the performance reports that we're seeing in a lot of areas, a lot of green shoots and improvements coming through. So that's all the hard work all the teams are doing around co-creation and working across the system, which is really positive to see. And in particular, the shifting trends around out-of-area placements and our temporary staffing, particularly the focus around medical agency, which will hopefully then start to give us the sort of the financial recovery that we want to see going forward. We had updates on our sustainability and clinical services strategies, and the committee was assured in terms of the progress being made there. I think 24-25 will have its challenges, which Dave will talk about in a bit more detail. We have now, as Roisin said, got direction from NHS England, in April. It's just ridiculous, really, from a non-exec perspective, and it's very difficult to manage anything without that direction. But I think the team and the trust have done an extremely great job in terms of trying to second guess and anticipate what's coming down the line, and I think we're in a really positive position for 24-25 going forward. At a system level, we had a system level conversation around our finances a couple of weeks ago. I think the sort of the challenge is increasing in terms of, I think at the system level, if I'm correct, we're going to be looking to try and post a break-even position. That's a huge challenge, which will then impose more pressure on where we're going to find cost savings across the trust, and how we do that in a much more transformational way. And then finally, the thing I wanted to just point out, we improved the extension, I think is the right word, of the Reach Out business case, and it was great to see have Kumar attend and present and talk about all the great work that's been done there.
Just to clarify, that was from the provider perspective.
Yes.
Because that would be the commission with the on today.
Yeah. Are there any questions?
Again, just clarify and then say there was an endorsement of the capital programme.
Yes. Just know that. Brilliant. Okay. Dave. Okay, so you've got the next two.
Okay, so I won't take a lot of time and integrate performance, but I've already said significant improvement around a number of areas. It is being sustained. We're not where we want to be, but we do know that we are making good progress around the right area. and the talking therapies part, although that is depending on staffing. There was one point that we flagged up and almost referred to it earlier on. So when we looked at the overall piece, we noted incidents resulting in harm where it was worsened, and we said that should have been raised in Q1, but I think the rest of the sentence had been. But what we thought might not have been raised was the difference or how it breaks down into individual areas. So there were significant increases both ICCR and specialties on the previous 6 months. So we weren't sure if that type of granularity was going to be QFES, just asking whether it could be or how could it be, to make sure we understand if there are those trends coming out of that. Because both of these areas, mainly community rather than inpatient, so that does tell us something. And I have to answer any questions, but that's all I was proposing to say. You have got the detail there about the deep dives, etc. We did spend quite a bit of talking about this and what they tell us, and that improving work.
Any questions?
Yeah. So just on the people side, I think we've got that matrix around bank and agency fee rate, where we're starting to have some conversations around matrix that makes sense around driving down bank and agency rather than just the fee rate. So it's just to flag that.
Absolutely. I mean, a lot of these metrics we probably need to be looking at different. We did talk about a previous board development session, and we will bring back to what are the measures that we want to use, rather than the ones that we have historically used, and that's what I'm doing.
And just quickly to note that we're planning on so some of the metrics will be counting things differently, particularly talking therapies and how we record and monitor out of area. The latter being, to report on a monthly basis, but we will continue, under that doing it on a weekly basis and absolutely sticking to our productivity plan. So, yeah.
Because that's helped us.
It is absolutely,
sorry.
Yeah.
And there is clearly a difference between what we need to report versus what we need as an organisation.
Absolutely. So we carry on that.
Thank you. Do you want to move on to finance report?
Okay, so again, not repeating what's already been said, Bart's covered some of this. We do expect to generate the small surplus for the year that we can talk about in a couple of months. We know that the reason for that in many cases is the level of non-recurrent savings we've been able to make. The outcome we've already talked about earlier on about the work that's going on around agency, particularly medical roles. I'm going to say a bit about 24-25. The capital expenditure, we're almost certain to hit the plan for this year. We did get additional funding through from BSOL ICB around that. That's helpful. We did talk about that before. I'm happy to answer any questions, but I want to spend a bit more time on 24-25.
Okay, so any questions about this year's financial position before we talk about the coming year? Okay,
so going on to 24-25 again, it's already been said we've now got the planning guidance. It's really poor that it came out so late, but I understand why. But it's therefore we're trying to move that forward and get the definitive plans and budgets to be able to go out. We have done projections, and it might be that what's in the paper is subject to change because of that late plan stuff going through. We did submit an overall, I think it was 13 million was the draft plan we put in for this organisation. At the overall level, I think for BSOL, we were saying around 70 million, I think it was. Yeah. And the plan, as Val said, and the machines added into, is to try and get to breakthrough, so there are things still to happen around that. Even the first, just to reflect, even the 13 million that we talked about does assume we can make significant efficiency savings. So getting back to break even is even more significant. There are a list of the areas that we're looking at in terms of the efficiency level. A lot of those are around agency reduction and taking over the margin, i.e. income related to things going through. I've got a list in there. Also just wanted to mention in terms of what I need to talk about the capital programme for next year. So I flagged up from both of the committees point of view, they endorse what's in there. So we've got any of the proposed capital plan for the year that we're going into. And we're looking for approval today around that, just to reflect in there you've got this part, it's called IFRS 16, which relates to accounting for leases. That means in effect, leases become capital for reporting purposes. Now we've got a reduction plan from the release of B1. That means that you've got a gain, but you can only use them on ones that will be counted as leases. So there are a number of things that we're putting through there, but we can't use that money for other areas. So I'm asking for approval for that capital programme. I'm happy to go through a bit more detail on that, but I wasn't particularly going to detail schemes because in some cases, particularly statutory standards of backlog maintenance, there's literally hundreds of small schemes. So the process of coming forward with the capital programme involves us looking at the environmental risk assessments that are done, look at the work in terms of CQC and the doors and all that part, looking at bids from different service areas and quite a tight, robust prioritisation process, including the A, B, C, Ds in the services. So this is coming forward from that discussion, which is why it goes from the two routes of FPP and QPES, because it's got to support the process from that point of view. I wasn't going to say more than that. So if we can seek approval of the capital programme, that's what I didn't need into that.
I think we have both committees recommending it.
Yes.
Not challenging the capital plan at all, but I think we do perhaps need a broader discussion, be it at full or FPP or a development session around, you know, the ambition of the trust in terms of what that means from a capital perspective, and the gap, which I know is huge, but I think if we sort of lay it out in a sort of a financial waterfall, it starts to give us a little bit more sort of visual sort of impact of what that looks like. And then you can start to overlay some of the risks that we've got going forward, because, I mean, this really, at the moment, just keeps the lights on.
Yeah.
Probably, if that. And so that, you know, we just need to balance that in terms of what we would like to do and how we can work with SSL and others to try and leverage what we can.
Especially on that discussion of the development session with Shane and Neil, where we can talk about the estate strategy. There is work going on around that, so we've got the mechanism to be able to do that. So with that being picking up the type of thing that Linda talked about before, what's the standards that people should expect by present police? Which areas are not at that standard level, and what do we do in terms of the ambition? Because, to be honest, the last 2 to 3 years have been about safety on inpatient walls and doors, and that's diverted money into that area as opposed to a lot of discretionary ones. And I know Kumar is very alive to the need to put money into some of those areas for all the things that we've talked about, and we do need to get the right balance, and we've got to be able to explore that properly as a board. I think that's absolutely right.
Just on that point first, though, just wondering whether we can ask FPP to take the lead on doing that work. If you can't afford it, then obviously when that's developed, we can then think about where we take it from. But I just really want to touch on, I use words like, you know, it's going to be challenging, it's going to be difficult. I just want to really kind of emphasise that it is going to be really tough. And, you know, as Dave's already said, that, you know, our contribution to the 70 million deficit was already stacked up with quite a lot of difficult things that we're going to need to do and quite a lot of risk involved in it. As I've described as senior leaders, we've had this conversation more than once, and actually it's really difficult, even with that whole group of individuals, to think about actually what are the things we can do fairly immediately versus the things that we might be able to plan over 2 to 3 years that could make a big difference. And we are an organisation that, you know, some of the things that other organisations are still thinking about are how they use more electronic patient records, how they rationalise their estate. So even in our own system, we've got organisations that are using much more estate than we are. We've done all of that work, we've reached the benefit, efficiency-wise of those things. So I don't underestimate how difficult it's going to be. I feel really strongly about the fact that we have a strategy, we have a really clear plan, And that is in the long term where we must get to. So whatever decisions we make in the short term can't compromise that. There's a lot of debate happening in other organisations and other systems across the country. And a little bit of that when some of us were invited to a system-like meeting around, this point about the fact that we're currently slightly ahead of our trajectory around vacancies. And is that, should we reduce our overall workforce headcount? From a substantive point of view, I feel really strongly that that is what we should be doing. We should be really concentrating on that element of our workforce spend that is the least efficient. And we should be doing more around making sure that the substantive staff we have are supported to work in the most efficient way they can through the fostering of things that we're doing. But I just think that this is going to be an ongoing debate. So, we are here for the long term. We want our services to be here for the long term. It's so really important for us to get the decisions we're making that they're aligned to that.
Yes, just a few points. I'm seeking. First of all, there's the cost of living. I think and explaining the 2 years together. So in the old year just gone, which is it's just gone, isn't it? Effectively, we've increased the SIP program we've still got achieved because of the out of area treatments, bigger £5 million. And then noticed in the plan for 24-25, we've also got an additional cost of living program for £5 million. So are we talking about a new £5 million out of area treatments, or a doubling of that?
So it's in effect, it's saying what we planned to do this year originally, we plan to do is justice deferred. So we're expecting to make that gain during this year, we didn't, as been reported several times. So we're not doubling it, it's effectively, it's just moved back.
Well, I think if I read the monthly reports right, it looks like that we have achieved that. That's how it reports.
We haven't achieved the out of area. Right. So we plan to make a £5 million reduction. We've actually we're spending significantly more than what we were previously.
Yeah, sure.
So rather than getting a reduction, we got an increase.
Okay.
So we're planning to make a £5 million gain against, I don't know if it's the outturn budget, I'd have to check that through. But it's not in addition, it's replacing what we've done.
Okay, that's fine. In relation to budget set, so in the basis of this to and fro with the police and RCS, have we actually issued budgets to the?
I don't believe we've issued them yet, but we will be working through. So the fact that we only had this signed off really recently because we took a change, we wanted to make sure we got the planning guidance that's to work through.
Yeah.
What I'll do is following on from the meeting, I'll circulate something around says what the plan is in terms of issuing those.
Yeah, I was going to say that would be good to see sort of income, this initial income expenditure, budget position, plus workforce that's we've got this years to what the overall picture looks like by division and stuff, I'm sure.
Okay.
And the last thing is around the cost pressures, so you've helpfully set out the cost pressures that's been agreed, and really a lot of those are. Can't do anything about them. But there is going to always be the residual cost pressures. What are those cost pressures? Flavouring those are offset. We're about to kick into the long rest or okay. I think that's the on the line list of the board has, isn't it? Those things that may actually end up having to do because of quality reasons, because of the coroner's decisions, all those other factors. It brings important for us to get that flavour for them.
Okay. You've got a range of ones. You have got emerging things like that. You've also got some where, in order to provide a service or backup or whatever, as we do now as an individual organisation, clearly you need to resource it.
Yeah.
You need to increase it because people are pressed by the volume of work coming in. Increasingly, we need to look at system first. How should we do that in the new world as part of the system rather than try and do it yourself? If you try and do it yourself, you're just going to have to build up all these small departments, and literally you cannot sustain that. We could look at how you merge or bring things together internally, increasing our people need to be looking at the system first. What's the system solution? So, for instance, there was one piece where I think it was domestic violence support, where there was not option you either put in a couple of band sevens, but the view was taken that actually we do this working with the ICS So actually, there's no additional pressure in there due to that particular way. There is a whole mix of things. Some are, and the board will likely advise significant risk, inflation on them, the energy, etc. But it is a huge mix of different things, Vincent, I'd say.
Yeah, I thought that because I was thinking, we talked earlier about that sort of increasing demand of different services, how it grows and other things. But we haven't necessarily been able to increase our capacity, have we? And I'm just thinking that's going to continue, isn't it, that demand increase. So what will we do? Will we go overspend, or will we somehow leave that demand? Whatever we choose to do, there's going to be a risk either to the finances or to the risk of people in the community not being able to access.
So we do need to get that balance.
Exactly.
It's that explicit balanced risk position, so we understand.
So I think that's what I think after this, I think it'd be useful for us to get an appreciation of that, I think, to be honest. And not just from a money point of view, from our patients and the therapy care point of view. So.
We've got 4 things that as a board I would say is our responsibility to balance, which is one way that there's continued access to services, that we've got, that we're continuing to drive quality on, that we're making sure that we're looking after the money, and fourthly, that we've got the right people and motivated to do the work. That's 4 things that we've got to continue to try and get some balance around. And I think the challenge going forward is to make sure that the finances aren't driving all of our decisions.
Yeah.
I just need to just to ask, it is a significant change going into this financial year, realising in the paper the non-recurring savings, just and Sheen's point about the focus being we don't want to cut staffing. Could you say that we've done everything we possibly can within our gift to look at CIPs or to look at efficiency savings, and then also considering that the messaging that we want to get across to our staff, to our colleagues, because obviously that's crucial as well in terms of, we have staff who've been really, I won't say burnt out, but tired, exasperated, and then we're going to ask more of them to be efficient in what they're doing.
So that's 3 things. This is the one that's probably last year, so much progress, to try and get that balanced position. It's always about this balanced position. I think when we've got a situation of getting on for 20 million of out-of-area inpatient beds, that says there's something we either have got to reduce demand, increase capacity, or certainly do things differently. We've got to be able to manage that, to get that balance in. We've also got, in total, if you include bank, we spend around 50 million on temporary staffing. Now that can't be, at that level, good for continuity and quality of care. And you do need to be able to substantively recruit in. Those 2 parts, until you've done that, I don't think you can say with exhaustive things. And it's not about people working hard. Genuinely, it's not about working harder. It's trying to find a different way to do things. So, talked earlier on about the transformation. Winston mentioned that. It's remodel this so we do different things in different ways. So, for instance, if we are limited by the number of qualified nurses, how do we make sure they do only things that only they can, rather than do a range of other things? In some cases, could you put in more administrative text and that burden away? Can we reduce some of that burden going through? So I think we've got to be really clear, but also careful how we have that discussion with the staff at all different levels. People need to understand the situation, understand the approach that we're taking, and what we're looking for them to do. We've got to work that through with them. We do have, or I have quite regular discussions with staff side about how do we have that, so we're in this together, we're working. How can they help and work that through? And it's just trying to look at that in all things. And as Rasheen says, it's in the round. It's not saying quality will suffer because we're going to do this. You have to find a way to achieve both. But certainly, agency will be one that's clear. Agency or temporary staff cannot be good in the longer term for continuity of care.
Just to build on that really, I mean, we've got some good examples of where, and actually, there is a relationship between improving the culture and the survey and the ability for people to recognise that they have the ability to influence what improvement looks like. And so we know that we've got some really good examples around things like intensive rehab and recovery, which is been piloting a very different model of providing rehabilitation care to people that traditionally we would have put into bed-based services for periods of between 2 to 3 years, 2 to 5 years actually. And that is a less expensive way of providing the service, but it's also providing really great outcome. And the incentive for that improvement was around the patient experience. And there is an opportunity for us to build on that, but also to share it, so that people can think about, well, actually, what's the opportunity in our service area? That it won't be comparable, but there'll be something of that nature that people can celebrate is happening somewhere else and begin to think about our own business.
Yeah, I think just building on that, Chair, what Dave was saying there, just around, those conversations with the staff. So we do have a sustainability board where we bring, very much these slides to that committee and have the conversations with, with our leaders. And I think a good example, again, bringing in what Rashida says around our urgent care pathway. Having a way day with the staff and the staff saying, well, we can do this, why don't we do this? So again, that transformation coming from the front line, people who actually are managing how we work, managing our pathways, and saying we could do it better if we did it this way. So I think listening to our staff is really, really important. As well, was just the example around, again, the outer area in Rosslyn, big pieces of work. Again, sustainability board, that's just to put the challenge and said, I think there's more we can do there. Not that we're going to change what we're doing, but maybe tightening up on some of the things we do. And for example, out of area, I talked about, people medically fit for discharge, but unable to discharge them to their final destination, or to another unit or more support, etc., etc. So again, a piece of work around looking at that, and more of an investor say. So if we brought in 3 more staff just focusing on that, our local authority colleagues absolutely want to work with us. If we did this and had a team, which would cost, would cost us, but actually would drive us down because this isn't what good as outcomes. So it's not deferring or going outside what we've agreed clinically and spoken with staff about, but it's actually thinking about a little bit more we can do, putting on those areas of work as part of the productivity plan. So I think they're good examples of conversations. I think our staff absolutely embracing what we've got to do, but actually can we do a little bit more without having a massive effect on them or no effect on clinical outcomes and obviously on risk, etc., etc. You've got to really, really get that balance, which I think our staff have got a good overview of.
Yeah. And Patrick, then the last comment from Rita.
Yes, I think I was just going to say that as a system partner and relief provider, I think we have a really good opportunity around driving some of those efficiencies and transformation at scale. Because I think on some of these wicked issues that we've been talking about for quite some time, we won't be able to achieve that alone. So I think the more we start to ensure that we're maximising on that opportunity and us being a partner and a lead provider, I think we'll be more effective.
Yeah, just to add on what everyone said, we're looking at using a lot of different approaches, including the QI approach, to multiple projects across the trust, and see how that links with a lot of work we're doing, and also with primary care system partners, and getting the patients, carers and clinicians in the room to look at new ways of how we provide our services, being more responsive early on in the prevention and early, so that people don't end up having a crisis and needing inpatient admissions in different parts of the country. So we did a lot of work on the out of area, which is continuing, and like Vanessa said, there's a lot of communication with social care and the colleagues. But now we're focusing a lot more on the early side, and our primary care colleagues are very much engaged, seeing the benefits of the neighborhood teams and how we can all integrate early on to help.
I think what I found very helpful from this discussion is the scale of the challenge that we've got going in front of us. It was necessary for us to have this discussion and have it documented, that we can actually, evidence that we are doing all that we possibly can. We're exploring other ways where we can, save money, but it's not just about saving, it's also about maintaining the quality of care for our patients and also thinking about our colleagues as well and the impact.
any decision that we take, but also have on them, and including them, as Dave said, I sat on the list of live session, you know, including our colleagues along this journey with us, rather than doing it to them. They're also part of the solutions that we're exploring. So in terms of your paper, Dave, this is the right paper one, the ask from the board is to endorse the 5.3. Yes. I think we're all in agreement to do that. Brilliant, great. Thank you. So that brings us down to, don't know what we're reporting at, James. That brings us down to just living trust values. Monica, your reflections.
Thanks, Phil. I'm conscious of time, so I'll be brief. But I wanted to focus on something that's actually really personal to me. Some of you might be aware that I had an accident last year. It was quite a bad accident, it was quite a traumatic period of my life. And actually the board and colleagues, governors, staff alike all came together and were very compassionate about my needs at that time and how I could still interact as a NED on this board, and allowing that flexibility to do it in a way that fitted in what my needs were at that time. Very person-centred, which I think is, you know, we all want when we're providing services, but also towards one another as well. I wasn't able to be as involved as I would ordinarily be involved, for obvious reasons, but members of the board and colleagues made sure that I was kept up to date in terms of what was going on. So I was included in discussions, updated on things that were happening. That's, although I was out of kind of the mainstream kind of conversations, I still felt involved and included in those. And actually that situation also demonstrated how the board and colleagues are really committed to ensuring that it's business as usual, despite this curveball that's been thrown our way. And you know, we were down on NED members at that point as well, so everybody really pulled in together. So for me, that was that situation itself showed how we as a board, as a staff team and as governors are actually living the values that we want to make as a trust. And I don't think I've had the opportunity to say thank you before today, so thank you, I really appreciated it.
Thank you, Monica. That's, yeah, I like how you used your own personal experience there to actually demonstrate how we embody the trust values in your recovery and get yourself back on track. So thank you for that. Moving on to the BAF. Any reflections from today's meeting? Does anything need to be escalated to our BAF?
I think we did talk about what we're about to say. Now looking at it, it's on the corporate risk register, but it's actually rated at 16, so it should have been on there anyway. So I've just put a few messages out, we'll put that through, but that's one I think that we pointed out. So it's not a new one, it's just recognising that there is one. The question about the financial position of GP's funds, is there something we need to think about that maybe we just rephrase or get the BAF right, because the BAF tends to be looking at things in isolation rather than balance. It might be. We just need to think about that going forward. I think that needs a bit more thought though, rather than, you know, their decision today. Yeah.
Any other comments? No? Okay. So I haven't got any other business. But questions from governors and members of the public in relation to the board agenda today are very helpful.
I came late in the meeting. I just want to say, showing the value, caring mind, up to Ardley and Rayside to deliver Easter egg to the service user and the patient that were quite good things. I just want to share this NHS employment, 1.5 million, highest employment for all the staff. Out of that is 265,000 out. People are not British, they're from outside working in NHS, social care, and that's really, and 90% of NHS home workforce. And we have now highest, I've been here for a long time, 4,600 staff, and 500 of whom have been non-British. And Patrick started nursing from outside. I don't know how many improved. Our introduction to last week, there were 3 people, a couple from India and from Africa, nursing started. So that's the good news. And what Vanessa is saying about how they transform the talking therapy by productive plan. They can see the screen sheet where they can retain the talking therapy staff, and they're hitting the mark to 90 to 94%. And we need to have that. I'm asking the board to look into our staff. Staff matters to me. Without them not mattering, then I matter. So we have got recruitment policy. How are we going to retain them and get the best out of them? Have a break, have a holiday. Roshi keep on saying, have a break and take time off on holiday to recruit. We need them. And how are we going to keep them? If we keep them fresh and they'll be more productive, and then the question to you, how are we going to do retainment?
I think it's not an easy answer.
Because that option, your strategy is not for rainy day or adversity, they have to steady the ship.
Yeah, so I mean, there's not an easy answer. I suppose some of the information in the staff survey is telling us that, and some of the information we've heard today about levels of recruitment, but also levels of turnover and vacancy reducing, is telling us that some of what we collectively, those 4,500 people are doing, is having some impact. So what we need to do is be really clear about what's positively being experienced. And if that's not happening everywhere, how do we ensure that people can reflect on how they can enable that to happen in their area too? I think the work that's going on around things like rostering and looking at the M-host, which is that system, which is basically saying what should our establishments look like? They will fluctuate, but what do they need to look like? I think it will be helpful when we get to the conclusion of those to be able to say these are the things that we understand we now need to make commitments to going forward. But at the end of the day, I think the one thing that every single one of us can have control over is how we interact with others. So ensuring that each and every one of us interacts in the way that is in line with our values is probably the most important thing, that every single one of us, all 4,600 of us, can make a commitment to do.
Sorry, Patrick.
Yeah, just to add to what Roshi said about retention, we know that when we looked at exit interviews, why people leave the organisation, the top 2 things being around flexible working and also in terms of career development. We've heard today around how people are reporting that we are improving in terms of flexible working, however we need to do a lot more. And around career development, we've had retention plans that are more focused on professions, so nursing, allied health professionals, psychology, where it's very much around what opportunities can we have within the organisation to retain people. So knowing within the professions, they're now looking at opportunities for people to rotate within the organisation. If someone is working in specialties, they might think they might have forensic experience, then how can we support them in doing that rather than seeking that opportunity outside of the organisation? So I think there are many ways of retaining people, and some of that is personal to the individual in terms of their own aspiration.
Thank you. Are there any other questions? No? Oh, Sunny.
Thank you, Chair. It's not really a question, it's more just an observation. I think today, more than ever, it's highlighted the importance of how we've got to do things in an integrated way. I think the board today highlighted a number of risks that we've got if we take individual standard whether that be professional specific or clinical division specific decisions, because actually they will come and forward us in terms of, you know, our greater and valued ambition. And, you know, from a service user point of view, as, you know, I'm sure you've heard this morning, the opportunity to have the best possible care provided. And actually, I've been a carer, I've been a service user, and actually I know that when I go and need services, I'm wanting that continuity of care. I'm wanting somebody who knows what I need and who can enable me to get that. And if we can actually get that understanding, not only from a cognitive point of view, but actually from a behavioural point of view, across our services and across our workforce, we will then achieve all the ambitions that our strategic priorities have highlighted. So it's just an observation.
Thank you. Thank you. Good observation, actually. So appreciate that. If we haven't got any more, that concludes our board and public meeting.
I just want to say, you know what you said about Lucy. Roshan keep on saying, demand 17% every year. We need to be transparent. We need to tell the people who give us money, 17% every year rising, more people are treated. And the money is less, so how we are managing doesn't be a question. The 17% every year, we have more patients, money is shrinking, something of those. So that's a big question.
I think that's why a lot of these independent reports are so important to advocate for mental health services. So we have a responsibility to advocate, to use the information that we've got. But I think equally, particularly over the next couple of years, we're moving into a political climate of change, aren't we? But I think those independent organisations who can take that information and develop the analysis independent of the NHS is really, really important to get that message across.
Well, thank you. Thank you, everybody. That concludes our board and public meeting.